Okay, well, welcome everybody. I'm Jacqueline Fuller. I lead Google.org. It's Google's philanthropy focused on catalyzing the best tech solutions around the world for humanity. And today we have Dr. Paul Farmer in the house. Woo!
Wow, thanks. Nerd Fest.
Yes. So this is such a thrill for so many of us. In fact, as we were getting the word out, and we had so many people who are interested, Dr. Farmer, we've got people from Google offices in 41 different locations around the world. We've got Germany, New York City, Brazil, Mexico, Austin. Everyone wants to hear from you today. So we're so very grateful that you've come. And so the flow that we're going to have is we will have a conversation and discussion for about 20 minutes. We're going to then open it up for live questions, so get your questions ready. And if you're in one of our offices, off location, we also have a Dory. You can find it, just go Paul Farmer if you want to submit Dory questions, because we'll want to take all of your questions.
I'm having that tattooed on my arm.
Go Paul Farmer. So let me start by just giving a little bit of an introduction for the man who needs no introduction. Dr. Paul Farmer is a medical anthropologist. He's a physician. He's also an expert in infectious disease, which makes him the spot-on guy we want to have for our discussion today, which is going to focus in large part on the Ebola epidemic. He's one of the founders of Partners in Health, along with Jim Kim, who's now at WHO.
World Bank.
Oh, sorry, World Bank.
Makes a big difference. They're the ones with the money.
Yeah, even better. Even better. Partners in Health, if you're not familiar with their work, is really proving what's possible to deliver healthcare in the poorest settings. And Paul is also chair of Global Health and Social Medicine at Harvard Medical School, where you started, right, stealing medicines for the poor. He's the chief of...
I know that goes direct to NSA here.
He's the chief of Global Health Equity at Brigham and Women's Hospital. He's an advisor to the UN Secretary General on community-based medicines and lessons from Haiti. He's an author, of course. Most recently, To Repair the World, Paul Farmer Speaks to the Next Generation. And we do have copies for sale in the back if folks would like to get his book. Many people know of Dr. Farmer and heard of him because he's the subject of Tracy Kidder's biography, Mountains Beyond Mountains, The Quest of Dr. Paul Farmer, a Man Who Would Cure the World. In fact, show of hands, why don't you raise your hand if you've read that book? So most of the room is raising their hands. Actually,
raise your hand if you've read Women, Poverty, and AIDS. Thanks loads.
Yeah. All right, but I'm going to ask a serious question, actually. Raise your hand if that book, Mountains Beyond Mountains, changed your life in a significant way.
Raise your hands if Women, Poverty, and AIDS.
So just one last note that Paul is also speaking tonight in San Francisco at City Arts and Lectures at 7:30. So if you don't get enough this morning or you want to bring friends, invite friends, there's another opportunity tonight. So we also want to say thanks to Paul's colleagues and team who are here. Cassie is chief of staff. His cousin Ann is also a Googler, so well represented. So Paul, why don't we start just with a little bit of background about Ebola itself. So tell us, what are the most important things that we need to know? Why is this epidemic scaring people like no other? And where do you see it headed?
Well, you know, one of the things that's important to know is you don't have to know the kind of virus it is in terms of, that's not that important. What you need to know is we're pretty sure we know where it comes from, how it's transmitted. It's a zoonosis, as everybody knows. But what's happened,
meaning
it comes from animals, it jumps from animals to humans. Yeah. And what happened, and this has happened with every outbreak, is that primates are not, human or non-human, are not the hosts, right? We're accidental hosts. And so there's a lot of speculation, you've probably already read about this, that it's from eating bushmeat or a fruit bat with butterfingers, very clumsy fruit bat, drops a piece of half-eaten fruit and some kid. Wherever it came from, that's not what's going on now. What's going on now is person-to-person transmission because of a failed healthcare system, and or systems, because a region, right? And it's also, that's one thing, is and there are other ways it can be transmitted, but it's person by person. When you hear about burials or funeral rituals, still that's person transmission. The virus can be excreted after someone dies, is excreted, and infectious. But as far as we know, it's not airborne. It's spread through infected secretions. Second point, I think I would just move up on the list, is that you hear that the case fatality rate is really high. But what does that mean? It means that a lot of people who get the virus are dying. But it doesn't mean that they should die. And just for the sake of argument, I've been saying, again, just for the sake of argument, what if it's not the case fatality rate that should be 90%, it's the survival rate? And if we had that as our supposition, then we'd say, like, as you guys say here at Google, how are we going to work against this goal or this plan? And if the goal or plan is, let's make sure everybody survives, then we have to work really hard to make sure that people are diagnosed early, that they're given proper care. Because even without a specific therapy, an antiviral, and then there are people going to want to talk about this. We do have treatments for people who have, they present very often in what's called hypovolemic shock, right? So when you have Ebola, some of the first things that happen are abdominal pain, fever. Even with a fever, you start losing fluids. And then you have vomiting, diarrhea, and just as with any other cause of those symptoms, you're losing electrolytes, you're losing fluids, and the treatment is fluid resuscitation, right? And it's not any American emergency room can do that, even when someone can't drink, oral rehydration, like Pedialyte. So we got to remember that we're losing people who there's not a lot of T in the ETU, Ebola treatment units. That's the second thing. I mean, I'm only putting these orders because these are things I'd like everybody to know. The health systems issue, that we got to do better, and just to throw out on another one. Now there's finally attention being turned to Ebola. We should have done it a long time ago. I don't know if my friend Dan Kelly's in the room yet, but we were in Sierra Leone, where he's worked for a long time, in early June. Ebola had already crashed into the city, right? And it's never done that before. It's been an isolated outbreak, rural areas. That's where it started. But once it gets, into the healthcare system, here's a third thing that I think it's worth keeping in mind. It's a disease of caregivers, right? Not just doctors, nurses aides, but people who does the majority of caregiving? Women. Your mom, your your mom, your sister, your aunt. So, even the story from Dallas, it sounds to me like Good Samaritan. That's the way I read. Some guy trying to help a pregnant woman who has Ebola. And so those are three things that just wouldn't come up on the first blush that I think it'd be good to get into popular consciousness. There's a lot we can do. This is not a new kind of spread as far as we can tell. We've got to protect our caregivers. Okay.
And then just to set the scene a little bit, some people might not have the full context. You mentioned Sierra Leone. I was there a couple years ago, and I remember I met the only pediatrician in all of Sierra Leone. I mean, so you're talking about a country where the health system is already pretty fragile, and then something like this hits. So maybe a word about how this is impacting the health system, what response is in place, what can we do?
Well, as you know, Jackie, concision is not my strong suit. But I will say a word, and that is it has already made the health system fall apart. So that is also a done deal. The epidemic's out, and it already took down the health system.
Yeah.
In
So that
Sierra
means
Leone
that
and
people with
Liberia.
malaria, people
That's right.
with road accidents, I mean, it's
That's right.
cascading effects.
Exactly. And I think the same is true of Guinea.
Yeah.
Now, I haven't been there, but talking to Ghanaian officials, I think they'd say the same thing. It's having a very adverse. The majority of Ebola victims won't have Ebola. They'll have malaria, obstructed labor, some other problem that they would have ordinarily had taken on. So that means that our work, an emergency response, our collective work, has to be linked to rebuilding that system and to strengthening local capacity. Yesterday, a lot of you know Larry Brilliant, Dr. Larry Brilliant, who's now at School of Global Threats, but we were at a conference and he said, outbreaks are inevitable, pandemics are optional. And that is pretty pithy, right? Because you have to miss all these chances to have a pandemic like this. And, once it's in the global economy where people move around, it's really harder to stop.
Well, maybe just expand on that a bit, because I think for folks outside of the public health world, even understanding an outbreak versus an epidemic versus a pandemic, and the impact that can have, both in terms of morbidity, mortality, people getting sick and dying, but also economic impact on our region. So right now we're looking at the official numbers of confirmed are only about 7,000, right? But
That's right.
The estimate is that it's just tens of thousands.
Well, we know that
unreported.
We know that the doubling time just using reported cases, right? And again, I'm sure this is obvious to you, all you nerds out there, that reporting capacity is related to health systems, right? Strengthening. I was recently in rural Liberia and talking to a health official, and there are very few, right? It's although they had stood up an effort beginning in March, even out in the rural areas. And, I was asking to figure out the diagnostic capacity, is there Lassa fever here? And because I knew it's the same forest where it is elsewhere, and the answer was no. But what she really meant is we don't have a lab. So there is this problem also of, what fraction of the cases are reported, as you just said. And the modeling exercises, as I'm sure people saw last week, some of them are pretty grim. Yeah. But if you were talking about more than 1 million cases, you're also talking about inaction and failure, and I think we could stop that. Yeah. What do you think is, just so we can get our hands around how bad it might get? So now the deaths are in the thousands, maybe 4,000 or 5,000. Infections maybe in the tens of thousands, but predictions that infections could go up in the millions, could spread beyond that. What do you think? What is worst case if we don't do what we need to do and can do? Yeah. Well, worst case is really bad. And you asked me to define outbreak. I mean, an outbreak, as this was Larry's point, zoonoses cause outbreaks, right? Because there's contact, and there's a lot of it between animals and humans. By the way, the humans are winning, as many of you know, meaning the animals are not doing so hot. And that isn't because of Ebola. That would be because of us. So an outbreak is just a general term. You can have an outbreak of 2 cases, right? When you have, I would say that this has never really happened before. I mean, it's easy to say it's never happened before. But to move into this part of Africa, into cities, into the healthcare system, a lot of that is new at that level, all of it. It is usually the outbreaks are closer to the bush, or they also have been associated with poor infection control practices. The first outbreak, for example, ran right through a mission hospital, killing the nurses and the nuns and the patients. And so this is how it started. Okay. But it was contained, and this time it hasn't been contained. And, to get back to the economic question, again, this is all over my pay grade or out of my field of expertise. Actually, this is Dan Kelly, who just came in, who I was just talking about. If we have, well, even now with the number of cases that are reported, it's the economic impact is already quite palpable, right? Because air travel, ports, cross-border trade, and tourism.
Yeah,
they've already badly affected.
Center for Global Development's got some good graphs on that in terms of the aversion effect.
Yeah.
That is not even just direct loss from trade, but aversion, people just avoiding the entire region, and what that can do to entire regional economies.
So I think we're already in trouble. The question is just how do we get out? I mean, as a species, obviously, I'm all for thinking of this as our collective problem, and we're also happy that, as far as I can tell, the people in charge in those countries have said we want help.
Yes.
So and that doesn't always happen.
No, there's a lot more openness than we've seen with some other outbreaks. So, all right, one last question in the how bad is it or how bad is it going to get, and then we'll switch to solutions, I promise. But so we saw the first apparent case in the U.S. Tuesday. Should we be worried in the U.S.? Or other developed nations? Do you see this spreading in Europe, Asia?
I see it coming to Europe, but not spreading.
Okay.
I see it coming to the United States. Well, in fact, last week I got to play, Cassandra. I just sang on CNN. First of all, they put me in a room where I was supposed to be doing a talk show, and I'm the only human in there, looking around and saying, hello. 50 minutes, no human. Anyway, I said, okay, all right, I did it. I confess. But, when this disembodied figure came on the
you did the satellite
camera and said, well, is this going to come to the United States and Europe? I said, well, sure, because it's a global economy. But I agree with the CDC director, Tom Frieden. I think he's right. It's not going to spread here because we have the ability to do what's needed, which is isolate the infectious patient while actually giving him good care.
Yeah.
And then doing contact tracing, which is, as he said, bread and butter public health.
Yeah.
And to do it, it requires a lot of resources.
Yeah.
And that's the right way to do it. And I think that would happen in any case, it will happen in the European countries I've been to. It'll happen here. So I think we've got a very good chance of seeing cases, but not of seeing much in the way of person-to-person spread.
Okay.
I mean, it will happen as it does with every...
Unless the virus mutates and then...
Well, the virus will mutate, I've no doubt. The question of whether or not that will change is either its virulence or transmissibility. Viruses and bugs, they always mutate when we poke at them with antibiotics or other... So parasites too.
Okay. So then thinking about treatment, there's been an interesting sort of debate, discussion in some of the articles about what's the best approach. And so you have, say, Médecins Sans Frontières on one hand, advocating a very patient-centered focus, making sure we take absolute best care and best standards. You have WHO, CDC's sort of more of a public health mindset coming in saying, well, we need to try these community health centers. I mean, your thoughts on which, if you were the czar in charge of Ebola, what would you do?
Well, first of all, I think that unfortunately no one is really advocating for a highest standard of care yet. That would require, for the critically ill, critical care. There's this confusion. People think that supportive care means holding someone's hand. And if you're in hypovolemic shock, then you're just going to hold their hand while they die unnecessarily. So I think we have a long way to go before we can say that there's any real progress on the quality of care.
Yeah.
And again, that's not to criticize any organization, especially any that shows up early, to try and save lives. But what looks like a patient-focused versus public health, we're not even there yet. because we've got neither going on, and both could go on. And the one thing I would say early on in the epidemic is every time we've tried to oppose treatment and prevention, we've failed. Right? You integrate treatment and prevention. So if you can't drag people, pull people in, to your care, which involves what? Involves isolation. That word just means following infection control. Sounds bad in lay language, like supportive care sounds like singing Kumbaya. Please don't do that if I'm in shock.
Yeah.
Right? Please don't do that anytime. I went to Catholic Youth Organization. So just as supportive care is not singing Kumbaya and holding hands, so too is isolation. It's just a technical term to prevent the infection from reaching other people. And the best way to do that is pull people in with good care and good service.
Give them an incentive to go.
And
let them trust that the system's going to care for them.
Exactly, and feed them and let them, imagine, being shut out of modern medicine forever. I mean, there's never been a collision of Ebola and modern medicine before that I know of.
Yeah.
So then you have people showing up in spacesuits or something, and then you don't see your family again.
Yeah.
And that's and if that's going to happen, which it should, it's got to be linked to really a warm welcome and survival.
Yeah.
And that'll happen if we have food and medical care, and there's a way to do it.
Okay.
And that's where we should go and invest really heavily in improving the quality of care and making sure our public health is stronger. It took, in some countries that have been credited with stopping Ebola, it took really hundreds, if not thousands, of staffers to do the contact tracing, community health workers especially.
Yeah.
And that's the way to go. So even though you're right, everybody's saying, high standard of care versus public health, that's been a dead end with every other epidemic I can think of.
Yeah. Well, you mentioned contact tracing. One of the things that we've at Google have been thinking about across many, many teams is just what can we do? How can we be helpful? What could we do that's differential? So Google.org, we've invested about $500,000 to some groups like Médecins Sans Frontières, UNICEF, others who are doing contact tracing, thinking about how can we help with some of the best mobile tools available out there to help with epidemiology. We have our geo team, for example, that's helping to do things even like providing really accurate maps with roads and critical information on them. We have a creative lab group, for example, that normally works on general marketing, that's doing things like helping to create visual images to do communications so that people in low literacy environments can understand how to take care of themselves, how to take care of other people. Our crisis response team is, this is happening in regions, obviously, where internet penetration is very low, so some of our typical tools in our toolbox are not as effective. But we're looking at, can we be helpful in terms of people searching for information and providing providing information in hotlines. And Googlers, if you're wondering what you can do, if you're in the room, there's a badge set up in the back where you can go and donate to Partners in Health, some other orgs on the front lines. You can also join Ebola Announce if you want more information about what's happening at Google. But so those are just some of the areas where we're trying to think about how can we help in a way that best uses our strengths. But I'll just turn the question over to you and say, what should Google be doing? What should the tech industry be doing? What should Americans, what should the rich world be doing in general to help here?
Well, first of all, those sound like really just the kind of things that we need Google to be doing. I mean, there's more, of course, it will not shock you, that I think. And I just really like to formally introduce my colleague, Dr. Dan Kelly, who is, at least he was until about a month ago, he's an infectious disease physician in training, studying for, an MPH, and he's been working in Sierra Leone for some time. I said, time to go back to Sierra Leone, and we're actually headed off together along with our colleagues in a few days. So if you go out to the kind of places where Well Body Alliance works, or Last Mile Health, or Partners in Health's other sister organization in Haiti, that's Amis la Santé, which some of you, many of you have supported after the earthquake. You know, a lot of the very tools you mentioned have not been available to the poor, right? Even it's worse in those parts of Africa, you know, with internet penetration than it is in Haiti, which is, you know, bad enough. So we don't know what's happening, where cases are popping up, and I've seen that already being useful. Those technologies are already proving useful, and I would just encourage you all to keep pushing these out to the rural poor. The rural poor are the last ones to benefit, in my experience, from technological advances. And, you know, again, there's no reason that has to be the same next year as it was 50 years ago or 10 years ago. So that last mile issue of going to the people really shut out of modernity, you know, I think Google could push that, right? And another thing that I've found very helpful, it went out for 30 years, is this idea of, you know, which we stole from liberation theology, a preferential option for the poor. It's kind of a simple idea, but very radical. If you say you're a doctor and you can say, hey, you know, I take care of everybody, but my primary concern is people who are sick and poor. That kind of thinking too rarely invades foundations, educational institutions, universities, companies. And I'm only saying it because I think it's really helpful, because that's the big challenge. That's another kind of last mile. A third is, don't buy it when people say, well, this is really straightforward intervention. It's all about, and then fill in the blank, right? It's all about prevention. It's all about improving quality care. It's not all about either of those things. It's really going to be hard, and it's going to require the kind of tools that I think people here would take for granted. Now, you know, all that said, and the other thing is, please be patient with us. You're the ones who are the Googlers and the engineers, not us. I'm a doctor. It's like, I don't expect you to understand how to dose cefazolin or to use the right prophylaxis for malaria. I know that stuff, though, right? But we don't know from engineering or from IT. Well, some people on our team do, but not a lot of us, right? So we need you to be patient and to accompany us with the gifts that you have over the long term. I said this after the earthquake as well, you know, because earthquake in Haiti, because and we did some of the things that we said we would do. I'd like to think we did all the things we said we would do. We did build that medical center in central Haiti. We did make it the largest solar-powered hospital in the developing world. We did build a new IT backbone to connect it to the Harvard teaching hospitals so that you can see an X-ray in Boston at the same time that you see it in central Haiti. We did put a CAT scan, the first one in a public hospital anywhere in Haiti, in rural Haiti, and again, connected it to whatever goes through, you know, God or Google or whatever. So, but that
we'll go with the cloud.
That accompaniment is critical. We're begging, you know, be patient with us. You know things we don't know, and we really need that. And then third, you need this kind of work needs resources that can be, you know, turned on a dime. Why do you think all these huge bureaucracies, they've been there a long time? You know, the UN, very humbly, when I was there, and they were doing our transport in Liberia, you know, because there's no air bridge, right? The airlines aren't flying really, and it'll be worse now that you've had commercial carrier. I actually flew out. I just noticed on the same day as that patient or the day before, right? So I haven't finished my 21 days either.
Good to know.
If anyone gave me a hug. But it's going to make it worse, right? So the UN was very grateful that they got us around, including in the rural areas. But they were saying, hey, you know, we worked on this for 10 years, and then one epidemic and everything fell over. And that's the right humility, I think. Not everybody would say that, but they did. So one of the problems is that, you know, if you study bureaucracy, like the sociologist Max Weber, so aren't you scared that I'm going off on some?
Questions? No, just kidding.
Okay, I won't quote sociologists, but that flexibility, that only comes from discretionary capital. You guys know that in business.
Well,
you can't not know that.
On the subject of discretionary capital and what we can do, I mean, on your site, and this is something that we pushed when I was at Gates Foundation before Google, is that, if you ask Americans, how much do you think that we spend on humanitarian aid? The average guess is about 10%. And in reality, we spend less than 1% of our budget on humanitarian aid. So, just sort of taking a wider view now from Ebola, just on global health in general, global development in general, it seems like we're going to lurch from epidemic to crises until we spend some real resources in some real smart ways.
I heard Jim Kim said something really remarkable the other day. Well, I've been hearing him say remarkable things for a long time. But he said that he spends a lot of his time talking people out of talking themselves out of doing the right thing. And that's because, we're all so socialized for scarcity, right? And that's a bad thing. Because that is we can romanticize, frugal innovation, but I don't buy it. Sitting in the middle of a squatter settlement in Haiti or in a rainforest with no electricity, that is a dangerous kind of romanticization in the middle of an epidemic. And I know it sounds attractive, but we've got to have, like you said, more resources put into these problems. I mean, none of us, if we were critically ill, would not want to have care, and nor would we want our kids to, settle for or get the second best. That's how most of the people I see in a clinic or a hospital feel as well.
All right, so we're going to turn to live questions now, and we have a mic right there in the back, and then we'll also take some from the Dory. Can we get the Dory questions up? Great. So while people are working their way to the microphone, what's your message to the average citizen, in the empowered world and the developed world on, what can I do? What can an average citizen do?
Well, I think it's better to imagine that there's something you can do even to respond to a problem that seems so remote from your own experience. And whether you call that empathy or, it's not like pity or mercy are bad either, right? Those are not bad things. Yeah,
if I'm dying in that rainforest, I'll take it.
But exactly, and we should remember that. Like mercy is a good thing. In fact, back to my PTSD Catholic youth, it's one of the cardinal virtues.
Yeah.
On the other hand, if you could link that to solidarity, and then link that to pragmatics, that'll really help with a problem like this, right? So, in addition to watching wherever it is you're watching, or thinking, or listening, or hearing about a problem that seems remote, I think right now what that region needs most of all is some of that pragmatic solidarity, right? And they need help, material help with rebuilding a health system that could be more robust. And after all, these are all, areas riven by conflict in recent times, and those are transnational conflicts. And it's not like something that happened just in Liberia or just in Sierra Leone. It's not like blood diamonds, like they're wearing them on their hands, right? So thinking about that pragmatic piece, and then link that to organizations that you have faith in.
Like Partners in Health.
Like Partners in Health. I mean, we're proud to be part of that.
Badge, donate, and back.
I'll just give an example, something that gave me chill bumps and moved me very much. An American actor named Jeffrey Wright got it that there's something wrong here, that we can't give up on people and think they're all going to die when they have Ebola. And exactly what every doctor or nurse should have said, by the way. Wait, you're telling me that's because they have hypovolemic shock? And,
That's treatable.
And that's treatable. Or they're losing electrolytes, And so he started a public service campaign about survival, and to get the message out that, we got to fight for people to survive. Don't forget, when people survive, they become immune. That's what it looks like to us.
Yeah.
And that means
and gives hope
that
to
they
everyone
can be,
else observing them.
That they can be part of the solution.
I don't need to hide this.
Yeah.
I can come forward.
And they can help us in our work. I'm not immune. They are.
Yeah.
Now, not everybody's going to want to work on that, but that's just an example. People think, okay, there's someone who survived Ebola. What if they're part of the solution?
Yeah.
I mean, that's what happened with AIDS activism.
Yep.
Well, let's have Ebola activism. Let's make sure that they, there's a place for them to help. And I know it sounds kind of corny, but I feel that way about everybody, about global health equity. So everybody can help somehow.
Yeah, and I think that's part of the magic that ignited the generation, is that every person matters, and that we need to do what we can do to save everyone, because each life matters. So first question, I see Raquel, who's an engineer with Google.org and is leading our crisis response on this.
You said there's not enough tea in the Ebola treatment units, and that we haven't really reached the highest quality of care possible. So, and I want to understand, there aren't enough actual physical doctors, enough actual beds, enough capacity in the treatment centers, because in a lot of conversations we've had with various people, all sorts of health organizations who we've been talking with to see how Google can help, one thing that we've heard, and maybe this has changed, is, well, we don't need money, we need leadership and direction. And maybe this is more around some of the tech solutions we were talking about, but the sense that the money's flowing in, but for people, we need people who know how to execute, organize, connect, deploy, train, all these things. That it's people. But it seems like that may not be the case if it's really that we don't have enough actual physicians.
Well, I don't think that it's true that we have enough money. First of all, a pledge is not the same, as you know, as delivery. So that's just the beginning of a process to get to the last mile. So again, I would say that is incorrect. I've heard it too. It's just not true. We need massive resources and a commitment to delivery. We've studied this now. In fact, we've used IT platforms just to ask a simple question after the Haitian earthquake. How many of these pledges are actually delivered? And that's just delivered to a place where they could be delivered as services.
All right, how much of it actually hits the field?
And that's just a national capital kind of thing. Yeah. We found out the answer is not very attractive, right? So we need, we basically need staff, stuff, space, and systems. We don't have any of them.
What's the hashtag?
Staff, stuff, systems.
Staff, hashtag,
Is
staff, stuff,
Is that our
systems.
hashtag? I like that.
Yeah.
What's a hashtag again?
Oh, my.
No, I have a teenage daughter. She explained it to me.
We're going to do a little session afterwards. Okay, so I see.
Well, I'm not done.
Okay.
I'm just getting warmed up.
Well, you're getting warmed up, but we've got people who, it's going to be the biggest moment of their life that they get to ask you a question. So,
you should just take
and we've
one of my
got questions
classes.
from around the world, too. So, but go ahead and finish, and then we'll turn it over
Well,
to our next
it's just,
question.
I think we're counting on the discernment, of your discernment and everybody's discernment, because, first of all, most of that critical care is delivered by nurses, not doctors. You go into an emergency room, urgent care center, someone needs an IV, it's nurses. And I think if you go and you're a nurse or a physician, you go into an ETU and you don't see this happening for all kinds of reasons, but the reason isn't that it isn't needed, then we got to be tougher on ourselves, at least on the clinical side, and say it's just not enough. And again, if it were you, I wouldn't want you to have that kind of care. If it were me, I wouldn't want to have that kind of care if I'm critically ill. If I've got a hemorrhagic complication and a blood product will help me, don't say it's impossible to give blood, right? Let's say instead we got a long way to go on staff, stuff, space, and systems.
And Partners in Health, along with a lot of other orgs, are the ones who blew off blew up in this whole idea when people said we can't treat AIDS in a place like Africa. We can't treat TB. We can't treat multi-drug resistant TB. Partners in Health has proved that we can do it and do it in a very resource effective way. It takes the mentality.
Yeah, and I think it takes a different kind of idea of, again, of who the team is. It's the community health workers, but also the doctors. And if you go right through that list, but don't worry, I won't. Staff, space, systems, same things around AIDS. And again, just setting our sights higher.
All right, we got another question.
Yeah, I was just wondering if you could go a little bit more into what you think the sociological angle of healthcare in West Africa is and how you think Weber's work applies to that.
Did you really ask him to quote?
He did.
Weber?
I'm so happy.
Did, yeah.
I mean, I've been waiting for this since Google was founded. So Max Weber was this great sociologist 100 years ago. He wrote some classics like on bureaucracy, which I use in teaching global health. Because, and I'll just say the short version, concision not being my strong suit, that his predictions about bureaucracy, policy, moving away from charismatic authority to bureaucracies, all have come true. And the only reason to keep that in mind is that every time you fix as policy a standard, what if something new comes along? It's like a budget. You say, well, Ebola is not in our budget. Well, that means that your budget's wrong, not that the virus is wrong, And sociologically or whatever, politically, this is what happens all the time. And this is why you get big moral errors like, well, we don't treat AIDS in Africa, and that's, it's absurd. And it happens every time. And then you have to fight like hell to say, okay, what's the global health equity agenda? Forget about, the plan that we had. If it didn't have cholera in it and cholera smacks Haiti, you better change the plan. You better change the budget. And that, again, is difficult when you're socialized for scarcity and everything is about, well, let's do more for less. They're already look at the budgets of those countries from the public sector, into health. They're nowhere near, they're at India level per capita, which is very, very low. China's up here. Rwanda's above China per capita. That's why Rwanda has such a strong health system, is because they invested in it. And they brought partners in to invest in their plan, and they have to be able to change it, like I said, on a dime. And that's hard. That's where I imagine we're stuck in that part of the world.
Okay. Do you have a book? Sorry, do you have a book you could recommend or books about the kind of setting
Women,
priorities?
poverty, and AIDS, for sure. Say again?
Oh, so I was wondering if you could recommend a book that goes into the kind of setting of priorities in a bureaucracy that you were talking about, whether Weber or other people.
Meet me after class. Yeah, I do. I'll write some down for you.
And we'll publish it on Go Paul Farmer so people can have access to it too. So why don't I take a Dory question from one of our other offices. So what do you think tech companies like Google can do to aid the efforts in building a better, long-lasting health system in Africa?
Well, again, this issue of, hi, Dory. I wonder where they are.
Who's asking that question?
Can you tell? Ulaanbaatar. I think it doesn't matter. I was just curious.
Yeah.
I think one of the things that we could do, that you could do, is, again, this accompaniment idea, right? Because if you look at the way that business is done, contractually, contract is a beginning and an end, that's not what we need, I don't think. We need a long-term accompaniment model.
Yeah.
Because, it takes a long time to build systems. So, you could say, well, we're not in the business of building systems, but you are. That's what Google does, right? And you do this in settings where there's extreme poverty, no electrical grid, people tend to have their, and this is true, again, of all of us. Remember what Jim said, I've spent a lot of time trying to talk people out of talking themselves out of doing the right thing. Is accompaniment is a balm BALM for us from companies. And we just haven't had that many experiences with companies now, with some, or with foundations sometimes.
Yeah.
You know, and we need more, because that's the kind of fruitful relationship we would seek with a tech company.
Okay. Let's take another live question.
Hi. So, and correct me if I'm wrong because I'm not a medical doctor, but a lot of the initial symptoms for Ebola are similar to the common flu's initial symptoms. Do you think the media possibly drumming up an Ebola scare being in the United States could overwhelm the U.S. health system to a point where the few Ebola cases possibly get overlooked, and with too many people thinking they have Ebola when they just have the flu?
You know, that's a possibility, and it happens every time there's a big scare of one reason or another, right? I do think that with better diagnostics, let me just put it this way, I'll bet you everybody who's working in an emergency room or urgent care center is thinking Ebola all the time now, right? And the day after the Texas case, the next morning I was giving, I was teaching an infectious disease course, and I laid out, a typical presentation. Half the room, and it would have been malaria or typhoid, or half the room went Ebola. It was Ebola, actually. But so I think having a heightened, suspicion, as long as you're not forgetting the other much more common and treatable causes, I think it's probably a good thing. And we need better diagnostics. But right now, I don't think, it's a bad thing to have this ridiculously heightened sense that what if it's Ebola, as long as we know, where Ebola sits in the burden of disease that could cause a fever, weakness, nausea, and vomiting. It's extremely low, for sure, in the United States. And even in a place like some parts of rural Guinea or Liberia, it'd still be extremely low. Be much more likely to be, malaria. But it's good for everybody to be worried about it. The problem, as Jackie pointed out, is just, now that the primary healthcare system has tottered and fallen, getting it back up again is going to require linking that anxiety about one problem to linking that anxiety to all the problems that are common.
Okay, so we have a question from one of our other offices.
Why 5 minutes? I came all the way here from Monrovia, Sasha. I want another 50 minutes. This is your Friday, you guys, I know your famous work hour thing where you get
we got to get to our nap pods, so no, I'm just kidding. We're gonna actually have more time after this with Dr. Farmer and technologists, because he specifically want to spend some time with engineers. So if you're interested in that conversation, we are going to stay a little bit longer. But in the last 5 minutes or so, especially for our remote offices, why don't I'll just tick through maybe some of these questions.
Sure.
You can
run through
rapid
and I'll
fire.
Try to...
So you've said that understanding poverty and inequity requires many disciplines: economics, ethics, law, sociology. Oh my gosh, you're going to quote Weber again, aren't you? In your experience in communities, what disciplines are missing, and what do they need to focus on once they come to the table?
I think I can answer that in much more concision. I think history. Because we are a desocializing species. We can't even remember what happened last year.
Yeah.
Right? So an anthropologist will study anthropology, a sociologist, a psychologist, forget it. It's history. This is not the first rodeo we've been to. It is, as you pointed out, similar to HIV or similar to the previous epidemics of hemorrhagic fever. And I think if only we were a little bit more rigorous with ourselves about looking, at what's happened before. Not everything is new.
Yeah.
And so I think
we're relearning some lessons again and again and again.
And prevention, by the way, the prevention versus care, quality of care when it's poor, thinking it's high. It's just none of this seems strange to me.
Okay. Next question.
Hi. So I read your review on Rishi Manchunda's book, The Upstream Doctor, and I had a quick question about that.
How'd you like it?
Your review or the book?
My review. Women, Poverty, and AIDS.
Yeah.
Sorry.
I'll add that to my to-do list. So, given that upstream solutions aren't the easiest sell, they're long-term plays to tackle the source of a problem as opposed to the symptoms that people in the media focus on.
Yeah.
In your conversations with world leaders, what has been, I guess, like the data or the primary factors that motivate them to be catalysts for change at the levels they operate in?
Well, I think it's better to assume that their motivation is something good, and then entrap them into decency, right? And you feeling me? So I'm serious. I think to approach leaders with a hermeneutic of suspicion and not engage them in a chance to do something decent is bad for people marginalized by poverty and racism and gender inequality, right? Don't do that we shouldn't do that on their behalves, to say, it's not worth working with so-and-so world leader. The upstream, downstream, is another one of those classic lessons, right? There's a sort of Luddite approach to upstream, downstream, where we're saying, well, it's the upstream determinants are all important, but if you're already downstream, if you already have Ebola, like I'm saying, I want someone to be looking out for me. And, I was just saying, I was at Stanford and was, saying, I was stupid enough to walk in front of a car when I was a medical student, right? And I didn't have my MD, and I looked at my leg lying in the street and thought, hey, broken leg. I didn't even have my MD. What a great diagnostician. If someone had come over to me, leaned over me and said, hey, you should have looked both ways before you crossed the street, if an ambulance attendant did that, I would be really unhappy, right? That's what we do to poor people all the time. We're like, upstream, downstream, should have used a bed net, should have used a condom, should have done this, should have done that. History has shown us that we do that way too often. And so we can do downstream, that is take good care of people, as we're doing upstream, that is prevent people from getting sick. And that's an important thing to get across to world leaders as well. Because it's complicated, and they want something simple or low cost or cost effective. And all these things change, right? Something that's complex becomes simple. Something that is costly becomes less costly. Something that is effective becomes replaced by something that's far more effective. And again, the bureaucracies can't move rapidly enough. That's, again, why we need, we need room to move, and that requires resources. Again, staff, systems, blah, blah, blah. And that's very hard, I think, for world leaders to kind of, they're being told, here's your budget or here's your plan. Mm-hmm. In fact, you get derided for wanting to change as fast as the pathogens do. You get made fun of, which is imprudent, as we're now seeing with Ebola. It's a great question.
Why don't we have our last two questions, just both of you ask your questions, just one right after each other, and then that way we can get them in before our offices take off.
Hi. For those who are surviving Ebola, there's obviously a huge amount of stigma, and I'm just wondering how the health systems in West Africa are treating the survivors.
Well, I don't know, but, I don't know enough, but again, to quote Jim Kim, he's, we should hire every one of them. I think that's exactly the right logic. And the healthcare systems and the neighborhoods, neighborhood organizations, church groups, whatever, I think that's really going to be an important message to get out. And I'm quite sure that's why Jeffrey Wright was working on it, not just to get people in the United States or Europe who might see one of his movies. Again, I don't know where, I guess that's a kind of global phenomenon. I messed up again. But also to get the message of hope out in areas facing big burdens of Ebola disease. So I think that's just unfurling right now, and that we would do well, all of us, including those of us who are going to be working there for some time, to keep on underlining, how much we need the survivors to be part of the solution, and that we're with them. And I'm hoping that'll change very rapidly. And the health systems, again, remember the health systems are underfunded and collapsed. So they couldn't just say, okay, we'll hire all of them, right? But we could help them do that and strengthen the public health system by relatively minor expense, right? Yeah. One little happy thing, and I know you wanted both questions to be asked, is that when I was leaving Monrovia, they were just opening up a new Ebola treatment unit, and it was the Liberians and working with colleagues mostly from Uganda, right? And it was the day before the grand opening, and there was a huge crowd in front of the Ebola treatment unit. And they were volunteers. And there was all Liberians. They wanted to, people want to help. It's not just, and we got to help them help, right? Because we have resources. They have resources we don't have, but we have resources they don't have. And I think it's going to be the same with the survivors.
Okay, last
Great
question.
I have a couple of questions on the disease.
No, you got one question.
It's my fault.
On the Ebola, the disease Ebola itself, you mentioned that the survival rate is very low because the treatment options are not that good. Do we know the growth room for how much better the survival rate could be if we had good treatment options? And the second question is, I've seen all these pictures of people in spacesuits. Is that an overabundance of caution, or is Ebola really that infectious?
That's a good question.
Two good questions.
And you can answer them both.
Well, I don't believe it's an overabundance of caution. That there is and just to say one reason why, and then I'll go to the other, is it's one thing to wear this gear in an air-conditioned building, right? And even in the New York Times article a couple of days ago about Nigeria's response, they mentioned air-conditioned hospitals. And, in Haiti, when I'm about to pass out, I go into the surgery wing because it's air-conditioned. I mean, really pass out. Now, how long can you, there's no electricity, so how's there going to be air conditioning, here and there maybe, but how long can you wear that and be very careful? The people I trust most say about an hour, and then it's disposable. Now, there must be other solutions. That's part of we need to talk to manufacturers who understand this. It's too hot, right? So and what does that mean? It's too hot, you make a mistake, you get careless, you don't have on the right coverage. It's because, people look at a video at how often people touch their eyes or their mouth. It's not that it's, it's not like it's suddenly going through skin. So I don't think it's an excess of caution until we have the staff and the stuff we need to make it go very smoothly. So the other point, which I'm very passionate about, is this is just me saying on, live to the planet or wherever this stuff goes.
Live to the planet. Thanks, YouTube.
I think that we should assume that we are able to save the great majority of people already sick with Ebola. Why? What's the risk in saying 95% survival rate? The risk that I'll look like a fool? I don't care, right? I would like, as a physician and as a community health activist, I could care less if that sounds foolish to any of colleagues. Or if we assume that 95% of people could be saved, and we, pardon me, but bust our asses to try and get them diagnosed and cared for early on and do everything we can, what's the risk of having, an excess of zeal as opposed to an excess of caution? So I think that message of 90% case fatality is damaging. I've heard it before. Yeah. What's the case fatality rate of untreated pneumococcal bacteremia before we develop antibiotics, or for those who live outside of the antibiotic realm even today? It's probably the same. It's probably 90%. So I think we should believe that we can flip those numbers on their head. And that, this is a failure of delivery of basic supportive care. And when we address that and we say, oh, you were wrong, it's really 50%, that's fine, I can live with that. But until we address the failure of delivery, I'm just going to assume, based on what we know about the critically ill from sepsis, whether it's of bacterial or viral cause or hemorrhagic complication, that we should be saving everybody. And if it's not everybody's job to save them, it is the job of doctors and nurses and their family members, right? That's what their family members are going to care about, their mothers and their siblings and their children. And we've made this mistake before around every serious infection I know of, or cancer like acute leukemia in children. We've got to fight to do that part of our job.
Yeah.
Thank you.
So a very important message from Dr. Farmer, I think, to all of us, charging us on towards pragmatic solidarity. I think for Google in particular, thinking about how we can lean in with our technology for the long term with a preference for the poor. I'm going to steal that too.
I stole it.
Yeah. So let's all thank Dr. Farmer for coming here today and his message for all of us.
Thank you very much. Thank you.
Really appreciate it.
So much fun.
Thank you. Thank you.